will occupy another 20 minutes. Maybe we'll take some more questions at the end of the session. Good. Some of the images are really disturbing. So I just give you a gentle warning. And there are images in the presentations. Please don't misuse. So in this talk, I'll be discussing about anatomy of the neck and the modes of injuries and how effectively we can manage neck trauma. At the end of the talk, probably you will be able to identify and manage neck trauma, and we could also predict complications. We could launch a poll. We have few polls, so we could launch polls. Just I want to ask how many people or how many doctors manage the neck trauma. You could answer the poll, and we can also, it give us an idea how many of you are familiar with trauma management protocol. Right, so that sounds interesting. So 36, 1/3 maybe managed. That's good. Good. Next slide. Right. Coming to the anatomy of the neck, we have 3 distinct zones in the neck. It's worth remembering this because when you describe the neck trauma, it's important to understand or know where is the trauma. Is a zone 1, it's in the lower part of the neck. It's possibly, as a rough rule, in between the clavicles, below the cricoid. The second one is, or you can see, is a zone 2, which is actually a mid portion of the neck, which normally contains major blood vessels like carotid, vertebral artery, and laryngeal cartilages, trachea, and esophagus. And the one above is a zone 3. It mainly contains skull base, vessels, and cranial nerves. As you can see, zone 2, you can commonly get a trauma in zone 2. But the advantage of the zone 2, it's wide. You can easily control because of the good access. But zone 1, the trickiest part is the injury can extend into the thorax. Zone 3 is similar. Access is difficult. You could get other injuries related to the nerve as well. So what are the causes? Broadly, you can define the neck traumas or classify neck traumas into blunt neck trauma or penetrating neck trauma. Fortunately, blunt neck traumas are uncommon. Penetrating neck trauma is also uncommon, but it could go up to 5% of the traumatic injuries. Commonly, you can see stab wound, gunshot wounds, and RTA. These are the 3 common causes. But overall, in the world, stab wound is the most commonest cause of penetrating neck trauma. Even though the incidences are low, the mortality can go up to 6%. The gunshot injuries, the mechanisms are slightly different. It can cause a direct trauma or temporary cavitation, or it could send shock waves, which can cause secondary injuries. As you can see, blunt neck trauma is commonly caused by road traffic accidents, but it could be caused by assault or strangulation. This is one of the best papers recently published in Clinical Otolaryngology as evidence-based review. If you look at this table from that one, 70% of the world is caused by stab wounds, even in America, except Los Angeles. That's where they got more guns than knife, I think. So let's launch a poll 2. A patient present with a penetrating neck injury to the left side of the neck, just below the angle of the mandible, which is true. whether you intubate early or early nasogastric tube intubation, C-spine immobilizations, C-spine immobilization is not necessary. The question is mainly to assess what are we going to do first, A, B, C, D. Do we need to immobilize the C-spine? That's what we normally do it. But this is a penetrating neck injury. We'll wait for the answer. Actually, what they have said, cervical spine immobilization is necessary in stab wound. They said 51%. Actually, the correct answer is cervical spine immobilization is not necessary if neurological examination is normal. That's the correct answer. So that's because suppose if the patient is bleeding, let's discuss that throughout this one. So let's go. Good. Look at this picture. This patient is really unstable. Unlike the last one it is fine. There is injury, but there's no active bleeding. And there's no air bubbling. There's no obvious expanding hematoma, but there are multiple cuts in the neck. It clearly shows possibly it's suicidal. You can see that one. But this one is really bad because there's a knife in the neck. We really don't know the status of the general condition, and it is actively bleeding. I would strongly recommend to take the knife out in the recess. Okay, this is clearly a case of urgent case which needs to go to theater in a more urgent manner. It's a real emergency. Okay. So in this situation, do you apply C-spine? And answer is actually no. It's for if you think if it is a penetrating neck injury, especially if the neurological status is fine, that is C-spine immobilization is not recommended at this point. Okay, when you see the patient with a neck trauma, you have to make some assessment. Assume that you are in accident emergency. Look out for soft signs and hard signs. It's easy. The neck has got a lot of basic structures, particularly esophagus and the larynx and the major blood vessels. So hemoptysis, hematemesis is and dyspnea or difficulty in swallowing, subcutaneous emphysema, non-expanding hematoma, and focal neurological deficit. So it's acceptable to have the soft signs. The focal neurological deficit is okay, which is not okay if the patient is developing cerebral ischemia or stroke. That's not okay. Dyspnea is okay, but it literally is going to kind of severe stridor, really airway obstruction. That's a hard sign. Its hematoma is okay, but if it is expanding hematoma, which is not at all okay, he's going to die. There is active bleeding from the major blood vessels, which needs to be controlled. And the shock clearly not responding to the fluids. These are all the hard signs, which clearly indicates these patients need to go to theater immediately. So in the poll, we had a discussion before. For penetrating neck trauma, given that exsanguination can give 50% of the mortality from such injuries, so C-spine immobilization is not mandatory. Let's give the poll 3, please. The 17-year-old male present with a stab wound to the neck. Which of the following signs would be the strongest indication for urgent surgical exploration? Stridor, hypertension in the field, air bubbling in the wound, subcutaneous emphysema. It's a tricky question. You could answer stridor, or you could say air bubbling in the wound. Let's see what, or could say, oh, everyone said stridor. I would take that. That's a good answer as well. And air bubbling in the wound is also a correct answer. The hypertension in the field is not the real, because we saw that it's only a unresolving kind of shock that is the real indication to go to the kind of theater. Yeah, subcutaneous emphysema is clearly not the right answer. Okay, that's good. Let's move on to the next one. Sorry. Good. So what are the investigations you do? The basic investigations are chest X-ray, AP and lateral views will provide useful information. But there are many useful specific investigations which we will discuss later. But chest X-ray is crucial for any neck trauma patient. The signposting neck trauma is very important. What we are really looking for, is there any injury to the major blood vessels, or any cartilages are injured? Is there any injury to the pharynx and esophagus? Any other neurological complications? As I discussed earlier, so expanding hematoma, shock, not responding to the treatment, air bubbling in the wound, profuse bleeding, severe stridor, and evolving stroke or progressive neurological conditions is the clear indication for taking this patient to the theater straight away. So, as I said earlier, is a nice article published in Clinical Otolaryngology. It's worth reading. The old school always say any neck trauma, if the injury is below platysma or zone 2, take the patient to the theater. But we are not practicing this at this point. We are following more conservative approach. The reason is CT angiography. Previously, there wasn't kind of clear investigations which tells you whether there is any underlying vascular injury. But nowadays, the CT angiography is more specific and easily available, and there are very good radiologists to report any underlying vascular injury. So let's follow the basic journey. When the patient comes to kind of an accident emergency with a penetrating neck trauma, you do all this A, B, C, D, E, and straight away assess the patient whether this patient is an unstable patient with the hard signs. That's easy. Secure the airway and arrange a surgery. Okay. If the patient is stable, it means still there may be potential injury. So think about any further injury related to the vascular or pharyngoesophageal injury. You may have to carry out appropriate investigations like contrast swallow esophagoscopy or angiography or CTA for vascular injury, or further history and examinations for this is all the stable patients. There are other groups like asymptomatic patients. Still, you closely observe them for 48 hours, then you could safely discharge them. So that's the three, roughly you categorize signpost into three different, is it unstable patient or a stable patient or asymptomatic patient? When we talk about the neck, we always talk about stridor and airway. This is one of the comprehensive slide. As a ENT surgeon, you always have a flexible nasal endoscopy and you work very closely with anesthetist to secure the airway. Sometimes you may have to use a bronchoscopy to achieve at least a temporary airway, or you may have to go for tracheostomy. It is worth considering what is the level of the obstructions. Is it injury in the facial-maxillary injury, the tongue, jaw, or is it along the glottis or in the trachea? In this case, particularly, we know the cause is a trauma more than the tumor or infection or inflammation. And it's worth assessing the severity. It's severe. It means can't even talk. If the patient is talking, it clearly shows the airway is patent, and that's an important sign. Most of the times, we need to assess where we are. Are we in the right place to manage? Are we in the research or HTU or in the theater or in the district general hospital? So this is very important especially when you make a decision about management of neck trauma. So what are we going to do next? You got a skillful anesthetist who is able to intubate, or if there is a kind of failure to intubate, whether we have expertise or skills to do cricothyroidotomy or doing tracheostomy for securing a definite airway. So these are the things worth considering when managing a neck trauma patient. We could launch a poll 4, please. Yes, which injury patterns would have a high risk of airway compromise? Tracheal injury, expanding hematoma in the neck, mandibular fracture, all of the above. I hope you'll be able to answer this question. I think we have briefly discussed. Let's see the answer. Good. I think 70% said all of the above. That's a correct answer, actually. I mean, tracheal injury is also correct, but airway compromise, even expanding hematoma in the neck can't expand because the hematoma is expanding. It's going to compress the trachea, and also it's going to compress the venous structure inflow. When there is a venous obstruction, whole pharynx and larynx become edematous, and we lose the airway. Okay. Obviously, a mandibular fractures, unstable or stable fractures can dislodge the tongue, and then that can cause the problem. Yeah. Good. So laryngotracheal injuries, I don't want to go into more detail about how to manage the laryngotracheal injuries because it's a very specified topic. There are some incidences you can have a whole transection of the trachea. You may have to intubate the patient from the neck through the open trachea rather than through the then after securing the airway, try and repair the whole thing. Some of the injuries could be managed by tracheostomy, then the delayed repair. Yeah. Coming to the vascular injury, we discussed earlier, there are 3 different investigations are available: catheter angiography or computer tomographic angiography, which is CTA, or color flow Doppler. But commonly we use CTA because it's readily available and it's minimally invasive. So that's commonly used. Let's start poll number 5, please. For a stable patient with a CT angio is normal. I think we discussed as well. Yes or no or not sure. Let's see the answer. Yes, that's very good. I think already they are following my lecture. I'm very glad. I think 86% said yes. That's absolutely correct. I'm very pleased. Okay, that's great. Let's go to the. So we discussed so far vascular injury and the investigations and the laryngotracheal injuries, and the next one is esophageal injury. Esophageal injuries are crucial because this is the common cause of this causes the mortality. because of the mediastinitis or sepsis and infection. Esophagus is closely related to the mediastinum and lungs and all these things. Okay. So the signs are pain while swallowing, hematemesis, similar to the esophageal injuries. They kind of vomit blood or blood in the kind of saliva. A surgical emphysema is one of the kind of sign, radiological sign, as well as clinical sign. It shows there is underlying injury to the esophagus. Okay. Preventable error on radiography can give you the similar. This is the important thing about esophageal injury. You need to have a high index of suspicion. The signs are very subtle. Or some centers assume if there is an injury, they always treat as a definite esophageal injury and do all these basic things. So let's launch poll number 6, maybe. So do you agree that early identification of esophageal injuries will reduce the mortality? Let's see the answer, please. Yes, that's fantastic. I'm glad. I think the answer is correct. Yes is the answer. Let's close. Yeah. Okay. Let's move on to the. So when you suspect esophageal injuries, contrast swallow or a similar swallow test will give you some idea whether there is any leak in the esophagus. So if there is esophageal injury, best treated by giving antibiotics and nasogastric feeding to keeping them nil by mouth. That will allow the esophageal injuries to heal by itself. If it is a large injury, it needs surgical repair. So the most important aspect in managing neck trauma is securing the airway and replacing the fluids, and sometimes starting antibiotics for if there is suspected esophageal injuries. Okay. I love this slide, damage control measures. Not everyone or every hospital is equipped with all these fancy gadgets or help. Many district general hospitals still they don't have a vascular surgeon or a CT angiography. If there is active bleeding, you have to carry out damage control procedure, which means it could be as simply putting a large gauze piece over the neck to control the bleeding actively, or you may have to kind of insert some Foley's catheter in the air bubbling wound and inflate, and then on top, you may have to add a lot of gauze and safely transfer this patient to the nearest tertiary trauma center who can manage these patients more effectively in a multidisciplinary team. So this is, we discussed some few cases. This case, you can see you have a staples in the neck with some kind of hematoma in the neck. Actually, this is a 5 days old post-trauma. Patient was managed and there wasn't surgically, but they stopped the bleeding. Patient was fine for 5 days. That's what it shows on the 5th day. And suddenly patient developed a massive hematemesis and he had a violent cough before that, and patient rested on day 5. So I took him to the theater again. When I opened the neck, there was actually food materials in the neck. What the forceps, what you're showing is a kind of is a breakfast in the morning. One is come out of the neck, and then further one. This is a thyroid cartilage. This is a superior part of the neck. This is the lower part of the neck. My scissors, it shows there is a defect between the thyroid cartilage and the pharynx, which wasn't picked up at the early time, and then that caused a massive infections in that area, then delayed bleeding, and patient actually had a kind of shock at that point. So we had to repair it at a later point. So as we discussed in the poll, so delayed injuries of the esophagus is common. So some hospitals routinely treat them as a nail by mouth for 5 to 7 days and making sure contrast swallow is fine. Then only they start the patient to allow the patient to eat and drink. This is a clearly a tricky case. You can see still the knife is in the neck, and the patient has been straight away intubated. You see, when the patient came here, the patient was actually talking and stable, was lying, and the first thing he wasn't having a stridor, but we intubated him. Is it the right thing to do? I think yes, because the patient is moving, active. He wasn't actively bleeding though. But we did intubate to keep him sedated and keep him stable. Then we transferred the patient straight away to the IR team, and we have done some investigations. Like you can see clearly, it's going all the way down to the thorax. CT angiography has been done, which showed this is a kind of aorta, and this is common carotid vessels and brachiocephalic. Luckily, there wasn't any vascular injury, but the interventional radiologist did this procedure for us. But how did we remove the knife? We didn't just take the knife straight away from the neck, but we did a thoracotomy first because we knew that that goes into the thorax. If there is any injury in the distally, if there is a bleeding, we can't control it. So we first did a lateral thoracotomy approach, make sure the distal control is fine. Then I opened the neck, and this was done with the cardiothoracic surgeon and vascular surgeon. So it's a teamwork you need. So that's how we removed it. So this case, actually, most of the cases, it could be kind of assault, but sometimes it could be suicidal. So you may have to address the mental health. You have to involve them as well. So that's an important thing. As I said earlier, this is a tracheal injury. You can see the trachea was transected, but it was repaired. So it's easy to intubate through the trachea straight away through the neck rather than through the mouth in cases to secure the airway straight away in A&E straight in itself. So I'm just coming to the end of the slides. It's controversy still there. C-spine immobilization, we talked about that. And what is the best way of securing the airway? Always there are talk about rapid sequence induction, securing the airway, and whether it's a conservative or mandatory surgical exploration. We are not practicing mandatory surgical exploration in all the cases. It's a CT angiography is the most basic and first line of investigations. If everything is stable, doesn't need any, could be managed conservatively. Laryngeal injuries management is always a debate. What is the best way, whether a plate or a stents, or when do you repair these things? So it's always there. So coming to the summary. So ABC is the most important for penetrating neck injuries. Cervical immobilization may not be as the first step. More about controlling the active hemorrhage is the first thing, will save a lot of patients. And if it is look out for hard signs. If it is unstable patient, secure the airway and arrange surgery. For the stable patients, trying to signpost the injuries with appropriate investigations. And for asymptomatic patients, close monitoring is useful, is recommended. So yes, and this is the Hudson River. I think the pilot hailed as a hero, and he saved nearly 250, I think almost all the passengers, because it's practice. He always imagined what he was hoping one day he's going to do that. So anticipation and planning is important, especially for neck trauma. Good. Any questions, please?
Joy, that was wonderful and fascinating, especially your pictures, which were also very dramatic. And I'm sure the audience have come away with some take-home messages that they'll remember. A few questions that kept recurring, and that is which you mentioned in your summary as well, the controversy with regards to C-spine, and there is some confusion as to why that is an issue. Why not stabilize the C-spine straight away and then sort the patient out?
Yeah.
And essentially, there's the confusion between, is it the airways that's more important, or is it the neurology that's more important?
That's good questions. Again, suppose, assume there is a knife in the neck. The patient is not bleeding or or kind of stable. So if you put the collar, you're going to disturb the knife. Most of the cases, the knife is fine or act like a kind of plug to stop the major blood vessels. If you disturb that one, you're going to either cause more trauma or you're going to kind of unplug that plug that causes that going to kill. But clearly the evidence shows 50% they die of hemorrhage, especially for a penetrating neck trauma. So that's why it's more, especially if there is penetrating trauma, cervical immobilization is not necessary unless if there is a progressive neurological weakness or that's what they say.
So that's much clearer now, and I'm glad they asked that question, because even in my mind it was a slightly worrying as to what you would do. So it's essentially not putting the neck, the collar, because you will then have to pull the knife out, and therefore you could cause more injury by just pulling the knife out. And that takes me to the next recurring question, and that is, if you are going to take a knife out, should you be doing radiology always? And I think you kind of answered that in your presentation, because you showed us exactly that. So don't pull the knife out, scan the patient, plan the management, and then do it in a controlled manner, is what you're saying, isn't it?
Absolutely right. Absolutely. Especially we don't even pull them, make sure we got a distal and proximal control, especially along with a vascular surgeon. And we make a plan, or we're going to kind of ligate or repair, and whether we got a proximal and distal control. That's a key in the surgical principle.
I think we've got time just for two more questions, and then we'll have to wrap up, because we are nearly out of time. The place of putting an NG tube, if you're suspecting an esophageal injury, do you not place an NG tube, or do you consider that only if you think that the esophagus is in continuity and you're not going to end up with the tube somewhere else?
That's a good question. It's if you think there is a high in putting the nasogastric tube, some occasions there's a radiologically guided nasogastric tube insertion is also possible if you're worried about, as that's a good question, because they are asking, there is a perforation, you insert the tube, instead of going to the esophagus, the nasogastric tube goes through the perforation into the mediastinum. So that's what the worry is. Most of the times, if the perforation, and you're going to check that post-operatively with the right place, then only you're going to start feeding. But if it is not in the right place, obviously, or if you have option of radiologically guided nasogastric insertion, that's also the best choice. Or While performing the theater's procedures, you do esophagoscopy under direct vision. You can still pass an esogastric tube.
I guess that's the safest way, isn't it? Doing it under direct vision, but that's not always the case. So that's great. The final question really was related to the vascular side of things, and if you've got a carotid injury or suspecting a carotid injury, I would think that you'd get the vascular team to join you straight away. But what else would you do, or can I do as a general surgeon, seeing this patient before you guys get there?
Yes, the carotid injury management is always debatable, but there are clear guidelines. Clearly shows. The first question is, are you going to repair or ligate? The recommendation is to repair, even if there is a neurological damage. Even the GCS is very low, still it says it's worth repairing. For repairing, you need a vascular surgeon. As a general surgeon or maybe head and neck surgeon, you sometimes you can acquire the skills, but I would recommend do it with a vascular surgeon, especially. So predicting these injuries is important. So that's why we recommend to have a CT angiogram before. But if you don't have the time and the patient is really deteriorating, and that's where it's become very tricky. But we straight away we call them straight away if there is any neck trauma.
Brilliant. I think that kind of wraps things up, but it's been a riveting session, really. Thank you very much. It's not usually that we discuss this sort of injuries, and actually they are life and death decisions that you make when you are faced with this patient in a trauma situation. So thanks again, Jai.
It's a pleasure. I hope the delegates or kind of enjoyed this talk.
I'm sure they did. The questions highlight the engagement as well. Just to remind everybody that on Thursday this week, we have Stephen Boyce talking to us on the management of bowel ischemia. Again, a very common problem that we face on a daily basis in our surgical wards. Thank you, everybody, and thanks to the college and to Jai and Heather from the webinar team.
Thank you very much. Bye-bye.